Kia ora tātou katoa, ko Mark Wilson tōku ingoa. I work at the Mental Health Foundation, and I pretty much work there because I have a lived experience of suicide loss. And I was meant to be talking to you today about suicide prevention, but I've decided, you know what, I'm going to focus on postvention and bereavement, which is in and of itself prevention. How you interact with your patients is vitally important, and I did a mini survey with my support group, and boy, I got some fascinating feedback about the experience of the GP interaction. So we'll go into that a bit more. So pretty much today I am going to focus a little bit on some stats. I think it's really important that we understand suicide statistics and some of the risk factors that may lead to suicidal thinking. Best practice languaging, talking with patients about suicide. Boy, oh boy, it's complex. And I'm coming here as a lived experience person. I'm not trained professionally in any of this, but it's what I've learned from my own loss and what I'm hearing from hundreds of people over the years. And I did this little survey, which was amazing and really quite special to hear what people said. And there are a lot of resources for suicide bereaved out there, and I really encourage you to let your patients access these resources as well. I lost my wife 17 years ago. She was 6 months pregnant when she died, and both her sisters had died before her. And 17 years ago in the world of suicide bereavement was light years behind what it is now, and our understanding and I guess how we talk about suicide loss. I worked for years in media, and then recently, 4 years ago, went to MHF and work in the comms team. So I'm on the Suicide Media Response Service, so I have to monitor New Zealand's media coverage of suicide, which is a really complex thing. And it was very complex this week with the suspected suicide death of Dr. Tom Mulholland as well, and trying to advise media on how to do that well. Again, that's another presentation for another time, I think, but we create suicide prevention resources, one of which we're doing at the moment, which I'm really excited about, is when a suicide happens in a workplace, how workplaces can work with staff and bereaved whānau. Hugely important, and it's something that New Zealand workplaces are missing out on. And probably I'm a member of the MHF Suicide Bereavement Advisory Group, and I run Solar Support Group. I've just left early this morning. I've been doing this for 20 years, once a month. We meet in Remuera, and I've just left 16 people to run wild. And again, it was just so uplifting to be with them this morning to hear about their experiences. And I'm working on, as a lived experience member for Auckland DHB, implementing zero suicide into youth mental health services. They're adapting the Queensland model. So suicide in Aotearoa, 538 people. Actually, in the next couple of weeks, we'll be getting the updated numbers. But as you can see, over the past 3 years, numbers have fallen. But it's still 1 to 2 Kiwis a day dying, which is 10 to 11 a week. Our suicide rate is 10.2 deaths per 100,000, and the OECD median is 12. So we often get this sense that suicide it's beyond awful, but in New Zealand, our suicide rates sit, about normal, except when it comes to Māori. That shockingly high rate of 15.9 per 100,000, which shows there's so much more work to do. And the same goes with youth suicide, and how we are the second worst in the developed world is, there's no words, and a lot more work needs to be done there. And I often see the devastation of families following, and it's so complex. So who's most at risk? Men, rural men, especially young rural men, young people. Māori, rainbow, and I think this is something that more and more I hear from the bereaved whānau of young rainbow people, is the care and the quality care and the understanding they receive about the pressures of being a young rainbow person in this world, which is far more accepting but also far more hateful. So knowing your patients well is critical. Clearly, those with whānau or personal histories of trauma, mental illness and or suicidal behaviour or suicide bereavement are more at risk. I have a lifetime risk of suicide now, and I want my GP to know that. And it's surprising how many don't fully understand that. And of course, poverty, social disadvantage and social isolation are huge impacts on increasing risk. I recently went to Slovenia for an IASP World Congress, and most of the keynote speakers were talking about the social determinants of health being influencing increasing suicide rates around the world. And thrown into this horrible mix, feelings of hopelessness, despair, and impulsivity. And when you've got that, it's pretty awful. Bereaved patient, the wonderful Julie Searle from the University of Kentucky, who I know quite well now, did some groundbreaking research in 2019, busted the myth of there were 6 people impacted by suicide and came up with a figure of at least 135 people are bereaved and adversely impacted by each suicide death, which means 72,630 New Zealanders last year were impacted by someone dying by suicide. And what's really important is to know that the exposure to suicide is on a continuum, and so people can be exposed, affected, and bereaved. And basically, if you're exposed to suicide, it's anyone who knows or identifies with someone who dies by suicide. And it's no longer merely just the focus on family members or those who are exposed to the trauma of the death itself. So suddenly you've got a far bigger expanse. So if you're at a university or a learning institute and a student dies, you may not know that student, but you've connected with that horrible loss and the impact that may have. So it's a huge impact, particularly on young people in schools. So I think we need to think far wider than just the small number of people. Interesting, the research pretty much says it's a similar bereavement experience to other traumatic losses like homicide, but it does come with some extra special things that I think sets it apart from other grief and bereavement. Certainly, I felt all of these, and I can talk 17 years on about this in a way that is when I was in the midst of my personal crisis, all of these things were very real and could be improved a lot by the experience of going to your GP. So certainly feeling rejected and abandoned either by the person or by your community or whānau. Huge feelings of shame and stigma. So oftentimes you just didn't mention that. I didn't mention that Zeta died by suicide. Many people then the access to help seeking becomes harder and harder. Your behaviour can change, alcohol, drugs, and the like, self-destructive, and you can feel suicidal. It's part of the whole grief experience. Certainly feelings of guilt and self-blame. What more could I have done? And I guess as a medical professional, you'll probably be feeling some of that sometimes too. And I think I fit into slight activism and rumination about suicide as well. But this activism is like a post-traumatic growth, I think, and for me, it has been continuing the legacy of my late wife, who set up this sort of support group 20 plus years ago, and I keep doing that. And I'm in a new relationship. I've got a young family, so I feel like my life is pretty damn good, but I see from the community how tough it is for many other people. So, how do you support somebody bereaved by suicide who turns up? It's an ongoing process, and this is the critical thing. It's not just the first visit you've had from them. So I had a wonderful woman say to me this morning, only half an hour ago, that she's alive because of her GP who had meals delivered to her home, gave her cell phone number, was able to connect with her when she needed to. And this was during the lockdown period, so for many bereaved people during that time was horrific. I don't expect every single case to be like this, but sometimes it could be the thing. It's really hard. So when you've got a short time to see somebody and it's all emotion and it's all random thoughts, and just listen, accept. This is a weird one. Try not to offer your opinions or advice when they've come to you, for often opinions and advice. But, it's part and parcel of trying to get to the right answer. This whole spiritual or cultural view is a fascinating one. I come across a number of different people from different cultures, and it's the shame and stigma that sits with suicide, that travels with them here, is really shocking when we know that suicide is still illegal in many countries around the world. It's still a criminal thing. Don't avoid the subject of suicide or what has happened, and this happens a lot. It seems that you're nice to somebody when they turn up for the first time, and then for the rest of your GP patient, life is never mentioned, and that really hurts people, which is why I talk about the person who has died. My GP did that all the time. She would be jamming something in my ear, taking my blood pressure, whatever, and she would ask me how I was doing. How are you? It was as simple as that. Ask about the well-being of other family members and how well supported they feel. Invariably, they're struggling with that. And be patient. It takes time, and acknowledging the loss over the years is super important. If you think they may be suicidal, ask them. Asking about suicide will not put the thought in their head. And this is my little unscientific survey I did. I sent out an email last week to my 200 people on my email list, and my inbox was full as a result. Mostly it's good. And there's some simple little things, I think, that could change, where it could be game changers. How's this? This is what we all want in our doctor visit. Empathy, understanding, not rushing to just give you pills and send you away. But then there was never any proactive follow-up. She didn't bring up our loss. I didn't think she knew what to say. And this was time and again. Everyone said that, and it hurts. And these are for people who might be 10 years on from their loss, and they still remember the fact that their GP never said anything. I didn't feel like she knew what to say or what information to provide. At the end of this, I'm going to give you some information so you can do that. The doctor was supportive and offered me medication to get me through the funeral. He also asked if I had support network. However, following visits, he never once asked how I was coping, assuming I was okay, as I didn't ask for any medication to numb the pain. This is a really important one, trying to bring that connection, and I think us suicide bereaved feel connection because we've got a lived experience and the same experience, and acknowledging your own experience of suicide loss may help. If you feel safe doing that, please do. And that was a beautiful statement there. And I don't know what to say, doesn't cut it. You can say that I'm sorry for your loss, and then explore a bit more if you wish. And this one I added because I really liked it, because it shows that it's not And this person who sent that to me, her son died over 10 years ago, and that's her abiding memory of a GP. And I think that's not a script. That's being kind, compassionate, and connecting. Well, the most important thing in this slide, I think, is don't use committed suicide. Instead, use died by suicide or took their own life. Nobody's committed a sin. Nobody's committed a crime. They've died by suicide. Also, Professor Rory O'Connor is a legend. He's from the Glasgow University. He did loads of presentations at this conference I was at recently, and his book is When It Is Darkest. Is evidence-based, so you clinicians will love it, but also it's readable for bereaved people. So I would highly recommend that. And also look after yourself. I think that's the most critical thing. You are going to be exposed to this as part of your job. It must be awful and hideous, particularly when the family may have questions of you. And that must be really difficult, because often with suicide death comes anger, comes blame and finger pointing, and we know that there's never one reason why somebody dies by suicide. And also heed the advice you give to your patients. Seek that supervision and support that you need, because it's a deeply traumatizing thing. I went to see my wife's psychologist, and I know I could tell she was so scared about that, but it was the most amazing experience for me. Don't know what it was like for her, but it was a really important thing for me to hear what she could tell me about Zeta. And that probably meant it was another part of my recovery and healing. We have loads of free stuff at mentalhealth.org.nz. Aoki Tara, which is the Bereaved by Suicide service, is a banging service. It's nationwide. It's 4 free therapeutic support services. You can choose the person you go to. It's amazing. Waves is another program that is run sporadically around Auckland and nationwide, 8-week program. A lot of people from our group go to that and really like it. It's a bit more, mine's a bit more free form, and there's lots of tissues, and we have nice baking and all that kind of good stuff, and fellowship and connection. And helplines, yeah, to a degree they work and help. And that's me. So thank you so much.